For myself, I think it was really good to speak to some people that obviously we usually wouldn't meet in normal circumstances, especially being up north. We're not quite central. So it was nice to kind of get our opinions and our views across and to feel like they've been heard.
Yeah, I think it's just speaking to the professionals, I think. So the pop-up stands that you had with that, which they would have seen online, would they?
I think you just can't beat coming here in person and being able to talk to loads of people that are here and ask all the questions that you need to ask. There's so many benefits to it. You meet lots of people, and it's just a really lovely feeling of camaraderie and interactivity.
So coming here, I feel like I've kind of felt like that I'm not alone in stuff that I'm going through at placement, and from what I've taken away from this is how to go about situations, how to make it better, and how to feel well supported as well. We had some top tips given, so going into placement, I just think I take them on board and try and make the most out of my learning experience.
For me, like the main reason I wanted to come was for that networking, for finding my people, the people that are interested in learning about the same things that I'm interested in, and taking those away and sharing them, and because we're on Midwifery Society at our university, and just kind of sharing those with our fellow colleagues and everything. So yeah,
I'm going to be looking back at the things that we've gone through, because there was a lot of content. But I think the joys of now that we can meet face to face, so that's why we really wanted to be here face to face. There is something about meeting other people. So yeah, next time sign up, definitely.
and welcome everyone to this week's Maternity and Midwifery Hour. My name's Sue Macdonald and I'm the curator for the Maternity and Midwifery Hour and the Maternity and Midwifery Festivals, and it's my pleasure to be welcoming our two lovely guests today for this week's Maternity and Midwifery Hour. And we've got Emma McKay. Is it Emma McKay or McKay?
Oh, thank you, Sue. It's McKay, yes.
McKay.
It's a bone of contention, but yeah, you got it right.
I know the feeling Macdonald doesn't often get mashed, but it does happen occasionally. And then we've got Sam Denny also from Australia talking about New Zealand, and it's 4 a.m. and the shortest day there. So welcome both of you to this evening's Maternity Midwifery Hour. Now, of course, we have to put our lovely guests on the spot and ask them to share a moment of the week with us. And I shall start with Sam. Please share a moment of the week.
Okay, so my moment of the week, my moment of joy in the week is that I have a friend with a disability who has difficulty in her electric wheelchair accessing my home. And finally, after months of wrangling and waiting, we had the men come yesterday and they have put in a little concrete path, which hopefully my friend Helen will now be able to navigate into my place more easily. And that is quite a moment of joy because it's taken quite a while, and it will be really a moment of celebration in 2 weeks' time when we can actually try the wheelchair over the driveway and make sure it works. So fingers crossed.
So it's a kind of, there's going to be 2 parts to this story.
Yes.
You'll have to let us know that it works. And I love your moment of joy, and I think that sums it up beautifully. Thank you so much, Sam. How about Emma? Could you share your moment of this week?
So yeah, mine's definitely a midwifery moment of joy. So a woman in my care this week, her first baby, she'd had the longest latent phase, 3 days, bless her, and she'd come into the hospital, was 4 centimetres, overnight was 4 centimetres in the morning, and you start getting those mutterings about, oh, it's not going to happen, it's a big baby, and those sorts of things. And anyway, the amazing midwife that looked after her just gave her everything she had, and they tried biomechanics several times. The baby was in a difficult position. Anyway, they tried biomechanics. Her waters she went from 4 to 8 centimetres and had the most amazing physiological birth. And when I went to see them yesterday for their first day home visit, she and her husband were absolutely over the moon. And, they couldn't stop singing the praises of the midwife that had taken such care and, not given up on them really. So that for me as a midwife is absolutely wonderful. And that midwife that looked after her, I intend to let her know about that amazing feedback. Wow. So important.
That's fantastic. That's a super story, because that sums up our strength as midwives and what we can really achieve. And actually it also, you say that, one of my favorite things is this Action for Happiness calendar. And a joyful June it is now. And the thing for today, it has a little thing that you do every day. It doesn't quite fit, but it almost fits yours, Emma. 21, which is today, send a positive note to a friend who needs encouragement. Well, I'm not sure she needs encouragement, but she needs that feedback is fantastic. Thank you so much. That's lovely. Fantastic. Well, we're going to come back to our lovely guests shortly, but the usual process is for me just to share with you where we came from. And I don't mean, right at the beginning of time. I mean, Maternity and Midwifery Hour was born in the pandemic, right at the beginning of the pandemic, when midwives and student midwives, or everybody in the health service really, was so focused on COVID and were not able to meet at festivals, study days, conferences. And we thought we needed something for midwives and student midwives and anyone else who's interested in maternity issues to be able to get together and connect, talk mainly midwifery and neonatal care, but COVID was discussed a lot at the beginning, and we don't talk about it as much. I'm just wondering if we ought to have a little revisit next time round, because it's still around and still causing problems, like with long COVID and everything. But this hour has been very useful for connecting people, and we've kind of carried on. And like everything else the Maternity and Midwifery Forum does, everything's recorded. So if you miss anything, you can catch up. If you hear someone talking about something in the clinical area about, oh, I listened to the hour the other day and it was this, that, and the other night, you can actually catch it up. You just need to go to Netflix and have a look. We've got, I don't even know how many sessions and hours now we have, but I think Neil Stewart, who's in charge of the whole maternity forum, and was saying it was something like 1,500 sessions. So that's a lot of information, a lot of knowledge. Perfect if you're doing a project, your dissertation, or an assignment for your course, and it's all free. If you want things very targeted, you can have a subscription. It's quite a cheap subscription, but you get a huge value, I have to say that. And that has it's kind of box sets with lots of added extra reflective activities and sort of targeted reading, and that can be very useful if you're short of time, which we all are. So think about that for the future. Also, we love you to share. So if you enjoy this evening, which I hope you will, I'm sure you will, share with your colleagues that it exists. I came across a midwife the other day who didn't know about the Maternity and Midwifery Hour. I was shocked, but not very shocked, because you have to know about these things. Word of mouth is very good, so do share with your colleagues and share the material you learn. It helps it stick it in your brain. If you're using this for revalidation, that's really important, because we need to reflect on stuff and add it to our portfolio of knowledge internally. Now, I'm going to say a big thank you, as I always do, but it's very sincerely meant, to all our midwives, our students, maternity care support workers, our medical colleagues, everyone in the maternity services who are working hard to keep the service going and keep it at a good standard, excellent standard actually, mostly for women and babies and families. So big thank you now. We know we've got shortages, which is having a huge impact on midwives and their well-being. So I'll also say, look after yourselves as well as you look after the women and babies and families. Now, I'm just going to do a quick news. Now, I did say earlier, it's the summer solstice here, so it's the longest day. And Emma did say a few minutes ago, well, the nights are going to start drawing in, but we've got a little bit of summer before that happens. So that's really nice. Interestingly, today is also World Peace and Prayer Day. We should have had that in a way last week, but I think the peace bit, it would be so lovely if we could have the world at peace a bit, and we can get on with living and enjoying life. You can always wish, can't you? Now, new out is the RCM, the Royal College of Midwives Staff Survey. They did a flash survey in March, and came out with about 4,000 people responded, and they came out with this report. Overworked and underpaid. Well, I mean, that would be a normal sort of perspective, but some of the results were very interesting. For example, and some of them, then they're going to be known to all of you who work in the service. Guess what? Midwives and MSWs are working 100,000 unpaid hours a week to support maternity services. Okay. 88% of the respondents worked additional unpaid hours. 74% of respondents always and often faced unrealistic time pressures and workloads. 87% of respondents, and this is quite worrying, I think, did not feel their workplace had safe staffing levels. And we need to be mindful of that and be able to feed back to our managers and anyone in clinical governance if it's not safe. And 26% of respondents worked more than 5 additional unpaid hours. The link is in the resources page, so do have a look at that. And I'm just also need to say, do remember to register for the Manchester Festival. Program's out, 4th of July, and you might also want to book for the Wales event, festival, Wales and Southwest. I need to look round now for when exact date, 12th of September, don't want to tell you the wrong date. And there you are. I'm almost at 10%, 10 past 7. So I don't want to miss a moment of our wonderful speakers. So I'm going to go straight into our main meat of the session. Now we're looking at continuity of care, and we've looked at that quite a lot over the weeks from different perspectives. And we were really pleased to be contacted by Sam Denny. And this is a lovely, lovely heading, the 94% continuity of care for women, the New Zealand way. But we're also going to have lovely Emma, who's going to give us a Welsh perspective of where we are in certain places in the UK, because it is different. So it's always good to have a sort of comparison to talk about. So I'm really thrilled to welcome Sam this evening. She says she is a nurse, midwife, mother, project manager, and soon to be grandmother. She's championed healthcare improvement forever. She's recently embarked on a new endeavour as researcher to support the ICM's push campaign for more midwifery-led continuity of care across the globe. Let's not do things on a small level, Sam, across the universe. Sam was also the lead midwife on a national project in the 1990s in Aotearoa, I'm sure I pronounced that really badly, in New Zealand, to reform maternity services with a lead maternity carer for each woman and her family. And they have developed a bundled payment system with detailed service requirements and referral guidelines, all of which are regularly reviewed and still in place. And that's a huge achievement, because often with innovations, the lead person goes, things change, go down a little bit. So fantastic. And Sam is currently project manager for a WHO IFEM project, and she's in Australia, but she will be talking New Zealand. So welcome, Sam. The screen is now yours, and thank you for coming to speak with us.
Thank you, Sue, and hi to Emma. And yes, many thanks for having me. One might think that I've done quite a lot of talking about all of this over the years, but in fact I haven't. So what you're hearing tonight is probably a little bit of a first, because whilst the New Zealand College of Midwives have done a fantastic job of talking the talk and walking the walk about New Zealand's maternity system, it has never really been explored from the point of view of those who worked inside the system to bring about those changes. So just to set the scene a little bit, and then I'll explain what I'm going to cover. But New Zealand, so, why am I giving this talk tonight? Why now? And why me? So New Zealand has a national continuity of care and maternity system, and all women get to choose who they want as their lead maternity carer. Now, sometimes, of course, they might struggle to find the one that they want, but in principle, the idea is that women will choose. Now, they can choose a midwife, they can choose a private specialist. Some will choose just to go to the hospital, and very few now will choose a GP obstetrician, more so in the past, less so now. So the 94% is really the number of women who are choosing to have a midwife as their lead maternity carer. About 6% choose a private obstetrician. So why am I talking about this now, 30 years on? Well, it is because it is 30 years on, excuse me. And I think that's important, because this system has really proved its point to a large degree. And I'm going to talk later a little bit about what works and what doesn't work at the moment. So we have good outcomes of care, and in the resources, there is quite a lot of information about the outcomes of care, and I'm not going to go into those in great detail. So why me? Why am I talking about this? Well, two things happened last year to me. I've retired from work, and I came across two things that made me think I need to get back into this maternity space. One was the ICM's push for midwifery, seeing the numbers and what a difference we could make in the world with more midwives really blew me away. And the second thing was a Commonwealth Fund report, and that's in your resources, looking at comparing the US with other high-income countries, looking at maternal mortality ratios. And I'll just hold up, you may be able to see, you may not, that little graph. Now here's the US, and down here is New Zealand. Now that astonished me. I thought, my goodness, we really must be doing something right. So what have we done, and what are we doing, and what can we do better at? So that's led me into thinking I want to do more research, more study in the whole area of maternity care. Why aren't we doing better in some places? What could New Zealand do better, even still, etc. So I was the lead maternity manager on the Joint Regional Health Authorities Maternity Project from 1992 to 1996. Now, you know, was that a long time ago? Yesterday, was it yesterday? My son would always say to me when I talk dates like that, he'd say, was that before or after Macdonald's, Mum? Well, I can tell you 1992 to 96 was after Macdonald's, but it was about the time of the internet. And I think I got my first computer in my office when I took up this job as the lead midwife. So in New Zealand, following Helen Clark's amendment to the Nurses Act, which was in 1990, midwives were no longer required to work under the supervision of a doctor. Now, that caused a bit of chaos, I'd have to say, I think. Doctors were not happy. There was a lot of controversy about it. And because the midwives were able to access the maternity benefit schedule, and really women were really able to choose to have an obstetrician, a GP and a midwife all involved with their care all at the same time, it meant that the fees went through the roof. So the joint RHA maternity team was formed as part of the health reform process of that time. It was a very small team, and we were responsible for redesigning the maternity system, managing a capped budget, and working through the changes that needed to happen to make the system sustainable. So there are some descriptions in the, I mean, there's been a lot of research done on the midwifery maternity system in New Zealand. And I have just included one or two very good papers, one from Greg and Tracy, which I think is a very good description in the resources, and another one which looks at the question by Dawson, which looks at the question of equity, which we're probably not doing quite so well on. I'm going to talk through what I think were the critical 5 elements that we put in place and that are still in place. So the most important, I'll just run through these briefly to give you a feel of where I'm headed, and then I'll go into them each in detail. So the most important was the information from and to women, the service specifications, the bundled payment system, agreements between health professionals and hospitals, and the monitoring of outcomes. Now, some of you will say, oh, we've heard all that before, it's a bit of a yawn. But I want to just go through each of those in detail because I think they are the critical factors which have made the system what it is today. So the information from women, we did a huge amount of consultation, and I mean really considerable consultation over a long period of time with many, many, many groups of women across the country. So I'm talking about Māori women, Pacific women. We had help from our Māori health team colleagues. We had help from our Pacifica colleagues to do this work. We met with disabled women. We travelled across the country. The 4 maternity managers in each of the 4 regions all took responsibility for consultation in our own regions, and we went out with our teams to do that. And we heard consistently from women, as you all know, they wanted continuity of care. That was probably the most consistent message we heard, and this was 30 years ago. So that became really an absolute pivotal point for us. And that led us on, of course, to the notion of the lead maternity carer. The second point, I'll come back to the issue of information to women rather than from women. But I will come, and of course, women told us lots of other things. They told us many, many things that were needed at that time. And I'm not going to go into those in detail. But they all formed our view over the coming 3 or 4 years of our work. So then from that, we developed the service specifications. And we developed the service specifications for primary maternity care, which was the lead maternity carer. And we developed facility specifications, secondary, tertiary, neonatal, etc. And with each draft of those service specifications, there were 4 main drafts, and they went to the health professional groups, and they went out to all the women's groups again. And in fact, somebody the other day found a copy somehow on the internet of the first draft, and handwritten on the front of it was all the women's groups that person or a person had sent on to other women's groups. So that's how the networking worked. And so there was very detailed work over a long period of time to develop what then became was then called the Section 51 notice, a terribly boring title. I'll just hold up for you. It looks like this. Not very, well, a bit boring looking, but incredibly important. It still looks pretty much like that. It became the Section 88 notice, which became the primary care notice. So those are things that anybody who's looked into the New Zealand system will be familiar with, because that is actually what runs the system. That is what tells the providers what is required of them. That is what tells women what they can expect, etc. Now, our vision at the time was, oops, I'm dropping my papers, I'm just going to read a little bit here. The prime focus of maternity services will be the woman, baby, and her family or whanau, which is family in Māori, and their identified needs as they relate to pregnancy, birth, and parenting. The quality of the services provided and the safety of the mother and baby will be paramount, including cultural safety for all women, and particularly for Māori women and their whanau. And it goes on. Now, I've had a look to see how much the wording has changed to the current version, and not a lot. It's been slightly updated, of course, to slightly new language, but the objectives of the primary maternity service are to give each woman, her partner, and her whanau or family every opportunity to have a fulfilling outcome to the woman's pregnancy and childbirth by facilitating the provision of primary maternity services that are safe, informed by evidence, and based on partnership, information, and choice, and recognise that pregnancy, and childbirth are a normal life stage for most women. So you can see that's developed but not changed a great deal in terms of intent. So the third aspect was capping the total budget. And I'm not going to go into that in a great deal. We said this is the amount of money that is now being spent in maternity care at that point in 1993 or 4. This is what we're going to cap it as, no more, no less. Now, of course, we put in provision for inflation over the years and so forth. And of course, the midwives have had to argue strenuously for more than that, as they have rightly done so over the years. So not a perfect system, and the College of Midwives would like to see a different contracting model now. However, it is, as it was, a bundled payment system. Then we put in place agreements between the health professionals and the hospitals. So access agreements between the midwives and private specialists in the hospitals. And there's a template for those I've put in the resources. And most importantly, the referral guidelines. And I would have to say, I would really stress that the importance of the referral guidelines. I don't really see how a system can operate without there being complete agreement between midwives or primary carers and secondary carers. Because as we all know, that's where it can fall apart if there isn't that agreement. I'm just going to have a sip of water. So what interests me, and I think probably will be the subject of my dissertation, is why are the referral guidelines in different countries so different? And I don't mean the clinical detail, I mean the structure and format and process of the referral guidelines. Even between Australia and New Zealand, they are completely different, and yet we are it is the one college of O&G specialists and two colleges of midwives that work enormously closely together, the New Zealand and the Australian College of Midwives. And yet I've seen written that these referral guidelines are similar, but I don't think they're similar at all. I think they're vastly different. And I want to explore that a little bit more and how they work, and are they working, to what extent are they working? And then the fifth thing is the monitoring. Of course, we needed to put monitoring in place. That faltered to begin with because the regional health authorities were amalgamated. We had a change of government in about 96, I think, 97, and we were amalgamated, and many of us lost our positions and so forth. And the monitoring was very slow to start, which was unfortunate. But it is very robust and rigorous now. And I have put the National Monitoring Group's report on the resources, and I've also put a link to the web tool that the ministry uses for monitoring maternity services, and that gives you your outcome data and so forth. So back to one, info to women. We then needed to make sure women understood these changes. So again, we had to go out and we had to write everything in a language that women were going to be able to follow. We put brochures in Pacific and Māori. We did a beautiful little brochure, which I happen to still have a copy of in my little box of tricks, expecting a special delivery. Now, you can see we have a lovely Māori woman there and two what we would call Pākehā, or English or New Zealand woman. And we have, what surprised me about this is that Aotearoa New Zealand, more and more New Zealand is being called Aotearoa, which is the Māori word, Aotearoa New Zealand. And I am surprised to see that we had that there all those years ago. But this was the brochure that was sent out to women, telling them about the maternity changes, how they would know where to find their lead maternity carer, etc. So we did a great deal of work in that regard. But interestingly, 30 years later, the National Maternity Monitoring Group still find that women don't necessarily know how to find a midwife. And of course, because there is a shortage of midwives in New Zealand, they sometimes can't find their midwife. And so consequently, there is still a great deal of work still needs to be done. Women are not always able to access a lead maternity carer early enough in their pregnancy. And there has been a lot of work done by the College of Midwives in this regard, and continues to be so. So how do we think the system is working now? Well, I think the monitoring group's report is an excellent report on what still needs to happen, what still could be improved in the system. And equity is certainly an issue. We still don't have the outcomes we would like to see for Māori and Pacific women, for young women, for women from lower socioeconomic areas, etc. All of the things that we see elsewhere. Perhaps they're not as perhaps we have made more improvement in New Zealand over the years, but still not enough. The other thing I've mentioned already is the sustainability. The length of career for a LMC midwife is worryingly short, because how sustainable is it to be on call 24/7? Now, some of them, of course, work in teams. Most of them work in small teams, but it is a difficult situation, and it's a shame that a lot of our GPs have dropped out of maternity care. How sustainable was it for them? When you're trying to travel across town and so forth to leave your busy practice, but it has meant that there is less choice for women where we had intended there was more choice for women. And I think it's something that's happening globally, of course. GPs, I mean, in Australia, they are absolutely the rock bed of maternity care because of the vast distances women would have to travel and do have to travel. So the small rural hospitals need the GP obstetricians. But in New Zealand, yes, it certainly did change. So from the point of view that I speak, which is inside the room, as I call it, those are probably the key things that happened. But I do have to acknowledge that there was a huge amount of other work that happens. The College of Midwives, the New Zealand College of Midwives work in this regard is just exemplary. And the midwifery training colleges, the universities training the midwives, absolutely fantastic. The women's groups supporting the system have, there are the ONG specialists supporting the system. Absolutely critical. I think that I hope I've given you, I'm going to wrap it up. I think I'm probably about my time, Sue. I hope that I have given a little bit of a sense of what it takes, what it took. It took a lot of courage. We had to negotiate. I think it took this document here, which says, where is it? Something about July 1994, maternity services 1994 and beyond. Well, we didn't actually put them in place until 1996. So it took 2 years of very solid draft after draft, going through every line of every draft with the College of Midwives, with the College of GPs, with NZMA. We never really actually reached agreement. We could have had agreement with one party or agreement with the other. We could not get agreement with both parties. And eventually, in 1996, we said, that's it, and we issued the notice. And once we'd issued the notice, the only way it could be changed was redoing that consultation all over again. So in a way, that simple legislative act really, I suppose, helped keep in place. Because as Sue said, people came and went, and most of us did not carry on in maternity, but other people were able to pick up where we left off and continue on with the good work. So coming back to the why, the sense, the why is because this is what women wanted. I think it's this, if you want to really boil it down, that's what we heard women wanted. They wanted continuity of carer, and that's how it happened.
Fabulous. Sam, thank you so much. I mean, I think it illustrates, I think, what you're, and it's a huge amount to get such a huge amount of work into 15 minutes. I know, but I think you've given a flavour of the important principles you need to really change. And one of the biggest thing is getting the women and getting what their views and what their wishes are, together with the midwives who are practicing, together with education, together with then legislation. And there was a sort of a thought as you were talking, I was thinking some of this, the midwives in 1902, the Midwives Act in UK will have been aware of, because it was so much, you had to be politically aware as a midwife there in that time, and you had to make friends in the right places, especially in political terms, to get what you wanted. And what an achievement. It's fantastic that it's still in place, even though it may not be perfect. It's pretty perfect. So thank you for sharing your journey. I hope you're going to stay for the questions. There'll be some questions coming. So any audience, just think about the question, put them in the chat room. I'd also say if you haven't been able to get the resources, they are there. So you can, or this is for the audience, you just refresh and they should come up quite clearly for you. So I'm going to move on now to our next speaker, Emma McKay, who's a community midwife working in rural West Wales. And I'm going to get this wrong, the North Ceredigion. Is that anywhere close? Team form part of the Hywel University Health Board Community Midwifery Services, and this team that Emma is representing today are passionate, and you'll see how passionate, about midwifery continuity of care and supporting parents to be in pregnancy and birth choices, working flexibly to provide holistic care. And the team have won loads of awards already for their dedication to their home birth services and recognition of their contribution to maternity and midwifery services. So welcome, Emma. The screen is now yours, and thank you for coming this evening. I know the last couple of days have been very, very busy for you, so I appreciate you being with us. Thank you,
Sue, and thank you, Sam. It was really interesting to hear you speaking about things in New Zealand. So I'm going to share my screen. I've got a presentation.
We just have to hope the gremlins aren't there.
Yeah. I'm trying to share my screen.
It's
the green one. Oh, yeah.
Ah.
There we go. Thank you, Amy. Okay, so yes, as Sue kindly introduced me, my name's Emma, and I'm one of the team of midwives in the North Ceredigion community. So we work within Hywel University Health Board, and just as a little overview of Wales as a whole, the red highlighted section is our patch, so to speak. So we're actually based, North Ceredigion, we're based within Bronglais Hospital, which is in Aberystwyth. And we cover an area that's about 34 miles long by about 19 miles wide. And so it's a fairly, probably not compared to New Zealand, but it's a fairly large geographical area. And obviously we may not have big caseloads, but the challenges of the travelling between visits can be quite immense, really. We work in close partnership with a hospital in Carmarthen that's about 40 miles away, called Glangwili. So our unit doesn't have a special care baby unit, but Glangwili does, hence why we work quite closely in partnership with them. So back in 2019, and I think this came from the Better Birth study, maternity care in Wales, a 5-year vision was launched. And of course, there were 5 key pillars of maternity care, one of which, of course, was continuity of carer. And one of the aims of this policy was to recommend that 45% of women and birthing people were to commence their labour outside of an obstetric unit. And I think for us as a team of midwives, we recognise that continuity plays a really big part in that, you know, empowering women, helping them to work through their birth choices, understanding the statistics and you know, the advice around safe places for women to birth. So a little bit about our team. So we're actually 6.4 whole-time equivalent midwives. Some of us work part-time, so we're 9 in total. And of course, this is really important because we know our managers have been very supportive in recognising that in order for us to be able to provide the continuity that we want to be able to provide, there needs to be enough of us to do that. Otherwise, we're going to become burnt out and exhausted, as Sam was alluding to. We're very, very lucky because our community office is actually based upon the maternity ward. So continuity, I suppose, runs throughout the care that we offer women and birthing people, right from the booking self-referral point all the way through to the discharge, you know, at the end of the postnatal period. But obviously we also have really good continuity because we see the women coming in labour and we hear about their birth stories. One thing I must add is that our continuity model doesn't include caring for women who birth in the unit. It includes women obviously who choose to birth at home, but the continuity model for women who choose to birth in the unit is for the antenatal and postnatal period. So I need to make that clear, of course. Yeah, so we're based on the maternity ward. In terms of our on-call commitments, 2 of us are on call each night. So obviously we're on call during the day as well, but that depends on how busy we all are as to who's on call. And so therefore we have to have 14 on calls in total a night because we actually cover the on call for the ward as well when it's busy. So it's quite a commitment in terms of on call. But again, managers have been really supportive in, we've had some changes on our ward, so there's actually more staff. So we get called in less so that we can honour our home birth commitments, which of course is really important as well. In terms of successful continuity, I think we'd all agree, and the pictures show it, that we're a really close-knit team. We obviously have regular meetings, professional meetings at work where we discuss cases, we look at notes, we look at birth stories, but we also have social gatherings too, which I think, you know, makes for a deeper bonding amongst our team, which I think just means we're all a bit more understanding of each other and we know each other a little bit more. So this is us in total. I won't go into everybody there, but we're all a friendly bunch. And then in terms of the way continuity of care works within our team, so obviously a woman or pregnant person is allocated a named midwife at the beginning of her pregnancy journey, and generally we would allocate a buddy midwife. So depending on the patch which we cover, we might have the neighbouring midwife to be our buddy. And the aim, of course, then is that just 2 midwives would see that woman or pregnant person, birthing person, for the duration of their pregnancy. So in a recent set of our North Ceredigion notes, our compliance with regard to antenatal and postnatal care continuity was 100%. So we work really, really hard to achieve this. We're very conscientious. Say, yesterday I visited a woman who's under the care of one of my colleagues, and we obviously worked out that I was going to be able to see her on her day 5 visit, and then I was also going to be able to see her for her discharge because my colleague's away on holiday. So we know then that that woman has seen her named midwife and only me. So we're managing to achieve that really well with good communication and careful planning. If I have annual leave, I'll cancel a clinic and I'll fit the women and birthing people around the times that I'm either before I go away or when I come back. And my colleagues will also do that. So we will make sure that we're flexible and we book people in so that we're able to maintain that continuity. And for example, when I visited the woman yesterday, I documented the reason why I was visiting her so that we're very conscientious about highlighting that we want to achieve continuity. So we document that the named midwife is on annual leave. We also have 2 NIPE trained community midwives, which again means that for women and birthing people who have home births, we can then go out and see them at home and perform that baby check as well. So that's really, really useful. And then just again, focusing on the flexible, holistic and individualised care that we provide. We as a team are willing to offer flexibility with our on-call. So again, you know, if I'm caring for a woman who wishes to birth at home, I'll try to be on call. I'll try and be flexible about my on-call so that I can go to her, and vice versa with my colleagues, and we'll swap and change our on-calls to try and facilitate that. And if we've got a number of home births due at the same time, we will try and offer a 3rd on-call so that we can, you know, try and honour those home births as best as we can and then provide the continuity that way. We're very lucky our core staff on the wards are very supportive as well. So if we've got a number of home births booked, we will often have core staff willing to do an on-call for the ward so that frees us up to be able to honour our home birth commitments. And of course, you know, as Sam was saying, you know, women tell us all the time that continuity of care is just not rocket science. I mean, it just makes absolute perfect sense. And we know that it's what women and birthing people want. And I know I speak for my team as a whole when I say that it is definitely what midwives want as well, because it brings such immense job satisfaction. And, you know, the feedback that you get from women at the end of their journey is so positive because they've got to know you so well. And of course, service users, as I said. And for us, we know that the continuity of care has led to a very positive improvement in our home birth rate. So in 2018, it was a combination of factors. There were some staffing issues. We had a 0.4% home birth rate. And then I can't see the slide. I think it's 6.1% in 2021. We have seen a slight dip in 2022. We don't know our figures for 23 yet. And we are appreciative that COVID may have played a part in some of those figures, but we definitely feel that continuity has also, because it kind of fell in line, the continuity model back in 2018 at the same time. So we feel it's been a very important part of that improvement. This is our team board. So again, you know, we share our home birth. Home birth just happened. We did pinch that off another team, so I'm not going to try and take the credit for that. But we do share the word about our home births with the maternity community on Twitter. But again, you know, in our office, this is such a lovely reminder of what we do together as a team, and, you know, the joy, happiness, empowerment, I suppose, that we can offer not only ourselves as midwives, but the women and birthing people that we're caring for. And I think this is really, really important. We obviously offer placement opportunities to student midwives. And, you know, they are our future, aren't they? And having the opportunity to kind of work within a continuity model is really positive for them, and we consistently get positive feedback from people, students that come and spend time with us in placement. So some photos of some of the students at various home births, and then this is a quote from a student that's about to qualify, actually. So I'm trying to move I can't actually see it, but I feel fortunate to have trained in an area where the continuity of care model is fully achieved. Apart from the labour on the ward, we understand that. Despite a challenging geographical landscape, the community team supports women and birthing people from a large area and works in close-knit relationships with midwives, obstetricians and professionals from a wider multidisciplinary team. This is a unique setup. And it definitely is. You know, we're very lucky, again, because we work on the ward, we can form really good close continuity relationships, I suppose, with our obstetric colleagues, and that makes a really big difference when it comes to supporting maybe particularly women who wish to birth outside of the guidelines. So that's great. And then finally, our service users, who are probably the most important people here, of course. So this was a lady that obviously was cared for by us. I think she just had her named midwife who cared for her throughout her pregnancy, and then she went on to be supported at home to birth. I'm so grateful to have been able to access such incredible care that enabled me to have the most empowering home birth. Giving birth in my own home was magical. I've never felt more powerful, and it had such a wonderful impact on my postnatal journey. And then Becky and I actually were very, very lucky. Becky's been the named midwife to the woman in the other picture, and she was the named midwife twice for that woman. And actually Becky and I were the midwives twice at that woman's home birth. So again, I've had the privilege of supporting this what an incredible afternoon. Midwife McKay and I have had the privilege of supporting a family's second home water VBAC with our team, birthing their baby girl in the kitchen. Amazing continuity as I'm named midwife, and Emma and I were present at their last birth. So, you know, I think that's really something to be proud of, and that those are common stories for us. We're incredibly lucky to be able to be midwives working within this service. And that's it from me. Thank you.
And what a lovely way to kind of complete your presentation, Emma. It's lovely because it makes you kind of think we should just do this. It's just, it doesn't make sense to do anything else really, because from a midwife's point of view, the rewards are huge, and it must make life much easier providing the care when you don't have to kind of meet the woman for the first time every time, as it were. So thank you so much for sharing your experience in the team. There's a few questions coming through. I did have a query and a comment. I love the powerful comment by the mother, but I had a query about the NIPE trained. Is that for the systematic examination of the newborn, or purely the 4 NIPE bits? Because I know that's something that midwives are now discussing because of the presence in, see, this is what I've got by the side of me at all times, in the NMC proficiencies, where we're meant, even midwives and student midwives are working towards the systematic examination of newborn, not, because I know NIPE is part of that, but
yeah, so the midwives within our team, they've done it for many years. I'm not, I must admit, I'm not 100% sure what the difference is, because I know Izzy that I mentioned, the student midwife, she's training to do it as part of her midwifery training.
Oh, right, okay.
So yeah, I'm assuming it's the same thing. I know
it's additional. It's additional because the NIPE was just focusing on the 4 areas, whereas the systematic examination is absolutely top to toe and taking in all the reflexes and all the rest of it. But I was just interested in the comment you made, so thank you for that. And 6.1 home birth in COVID time.
Yeah.
How fantastic is that? My goodness. It's got to go up even more.
a lot of services were cancelled, weren't they? So I think we felt very privileged to have been able to maintain ours, really, when a lot of services were put on hold.
It was absolutely fantastic. Fantastic. Okay, I've got a question from Jenny Gamble. Hi, Jenny. And Jenny says, and I think this might be for Sam, in what way are the referral guidelines different?
Well, hi,
And
Denny.
answer that in less in a shortish time.
Well, I think it might be the topic for my Bachelor Midwifery Honours dissertation, which I'm currently discussing. But I think, so it needs exploration. But what strikes me as the main difference is that the college, the New Zealand guidelines are very clearly signed off by all of the key parties. The College of Midwives, the obstetricians, paediatricians, anaesthetists, etc. The college, the Australian guidelines have been developed by the College of Midwives and are endorsed by RANZCOG. Now, that to me is different. There's a fundamental difference, and that's what I want to explore. To what extent are they really owned and adopted and used and honoured by obstetricians if they are merely endorsed? So that's, to me, that's something I want to explore. We might find there's not a lot of difference in how they are perceived and utilised. But the other issue is in the way they speak to what needs to happen. Is in the New Zealand guidelines, they are referral guidelines to obstetric and related medical services. And it's very clear there's a referral or a consult or a transfer or an emergency to secondary care. The Australian guidelines speak more to a referral to other practitioners. To me, that's vastly different. Now, it may be because of the different scenarios that Australia faces with the vastness of the size of the country and the many, many small rural maternity units. I don't know. That may well explain how they are different. But I think it's something worthy of exploration.
Which is what you're doing. Fantastic. We're going to have you back when you've finished your exploration, Sam, I think. Okay, thank you for that. Now, Jenny says, hi, Jenny Hall. Here she is. Says, how much of the success is due to managers being willing to release midwife teams to create their own timetables of work, or midwives being prepared to be flexible with their lives? I think that might be Emma's. Might be Sam's as well, but we could start with Emma. What do you think?
I mean, definitely. I think, you know, we have a really supportive manager, and to be honest, she has fought quite hard, you know, within our team to make changes, you know, to improve the amount of midwives there are, you know, in relation to the geography that we cover. Because I think on paper, the caseload, it doesn't look much, but you know, we've got a lot of travelling to do between visits, so we have to account for that. Obviously, we've got a big commitment with on-call, and as I say, we do honour on-call for the ward. So, you know, other teams that work within Hywel, they provide cross cover, so they don't have to provide as many on-calls because they're working with other teams to provide on-call cover to our sister hospital. But us as a team, we're the only midwives that provide on-call to our team, so to our hospital, sorry. So I think definitely supportive managers, but as I was saying, you know, the relationship we have as a team makes a huge difference to the way we work together. It means we're flexible, we get on, we've got the same vision and goals, you know. And I think the continuity is so much at core of that, because we all know the women and the birthing people, and with that comes a passion, you know, it builds a passion, and you want to be able to provide the continuity. So yes, I think it's a combination of factors.
So does it, are your team is obviously prepared to be flexible with their lives?
Yeah, I would say we are, yes. Yeah. I think, however, there's an understanding that, you know, there's people some of us have got children, some of us haven't. And I think there's an understanding that whether it's a family you've got, or whether it's you're wanting to go out and socialise, there isn't an expectation. You know, it's not that, well, we need someone to do the on-call as an extra tonight, you've got to do it. There isn't that at all. But I think we work together well to try and provide that if it's needed.
So it makes the teamwork really crucial. And that's great. Thank you very much, Emma. I've got another query from M. Hello, M. Who says, just to clarify, Emma's team offer full continuity to women who choose to birth at home.
That's
Those
true.
Women with additional care needs who will birth in the labour ward will receive antenatal and postnatal care. Surely that's the reason for increase in home births! !
I guess possibly. I mean, I think across the board we're seeing a rise in women and birthing people who might choose to birth outside the guidelines for whatever that reason. But I think that's the same across maternity services, full stop, isn't it, really? Yeah, that's an interesting point.
Well, it might. I mean, I can see that if the women, I guess that would count as an unplanned, or do you plan the place of birth when the woman is in labour? I suppose that's the difference, isn't it?
Well, we have a birth preferences appointment at 36, whereby we make a plan with the woman at that point. You know, maybe possibly discussions leading up to that point through the pregnancy.
Yeah.
So that's when we would make a plan for place of birth.
So women might make that choice, mightn't they? I think if I was one of those women, that's probably what I'd do. To get my continuity, I'd hang on to my midwife. Thank you very much.
Yeah.
That's fabulous. Thank you. And then we've got Jenny Gamble again having another go. Hi, Jenny. In UK, I hear the continuity of midwifery care is not culturally appropriate for UK. Thoughts? I think that I've not heard that one before, Jenny. Not culturally appropriate. I don't know, Sam. You're looking as though you might have an answer to that one.
No, I'm not really understanding what Jenny said there.
Well, I'll repeat it. In the UK, I hear that continuity of midwifery care is not culturally appropriate for the UK. And I think she's providing us with a little debate. I'm not sure. Jenny, we're dumbfounded. So we'll have to have a think about that. You might have to come along on the air and tell us what well, I think you need to open the debate, Jenny. Okay. And then I've got I've got Neil, and this is Neil Stewart, I think. Hi, Neil, who's saying, did the New Zealand no blame legal framework facilitate midwives practicing with confidence, do you think?
Well, I'm sure that when I think about the whole context of healthcare, there are a lot of differences, and what Neil is referring to there is a key difference in the way New Zealand operates, because there is a no blame culture, I suppose. We have an organisation called the Accident something or other, ACC, can't think of what it is anyway. And so the issue of insurance wasn't the same. It was much more of an issue. It has been much more of an issue for Australian midwives practicing independently than it was for New Zealand midwives, certainly. So I think that there is less fear of litigation. There is amongst obstetricians, hospitals, and midwives consequently. However, we have a very, very strong Health and Disability Commissioner who reviews every incident where there has been, less than good performance by a health practitioner. So it is not to say that there isn't scrutiny of all of our healthcare systems. There certainly is. But yes, I do know that midwives in Australia certainly have struggled with that issue of insurance, definitely.
No, I think that is an issue. Thank you, Sam. That's lovely. Now I'm told I've got something further from Jenny Gamble. Jenny meant in terms of culture of midwifery rather than different cultures.
So, I mean, I wonder if she's referring to a culture within the NHS, possibly.
Okay.
And I don't know, maybe we discussed it earlier, didn't we, that staffing issues are known to be quite a big problem. Midwives are leaving, aren't they? And actually it's very hard to recruit midwives because of perhaps the models of care that are panning out in certain areas and certain units. So I would say that maybe in a lot of areas that it wouldn't work because there's just not enough people on the ground to be able to offer that level of service, really.
That's fabulous.
Yeah, and I would certainly say we struggled with this in New Zealand in the beginning. There was a lot of difficulty between the hospital team midwives and the LMCs coming into the hospitals. And I met recently with a friend who was one of those hospital midwives. We happened to have dinner together after not having met up for quite a few years, and we were discussing this. And she said to me, "You didn't give us enough warning that this was going to happen." She was very, well, actually, I would say we gave you 4 years of warning. But anyway, the point is the message didn't filter down, of course. And so midwives, busily working away in delivery suites and so forth as core midwives suddenly found themselves confronted with this whole other system of care, and it was a struggle for quite a long time. I can't speak to how that is now. I think less and less hospitals offer less and less continuity of care midwifery schemes because more and more women, as you can see, are choosing a lead maternity carer who is a midwife. And you see, one of the things that I will just make a note of is that when women transfer to secondary care from their primary lead maternity carer because of the transfer guidelines, and I'll read you this piece, which is from the current notice. If clinical responsibility for a woman's care transfers to a secondary maternity service or tertiary, the woman's LMC midwife may continue to provide midwifery care to the woman in collaboration with those services. And by and large, that is what happens. Most of the time, the woman, I mean, of course, it will depend on how long the progress of the labour and what else is going on for that woman, etc., etc. But by and large, it is accepted that the midwife, the LMC midwife, will continue to be involved in the care and in collaboration with the secondary care team. And I think really, by and large, that is accepted practice now in New Zealand.
Okay, thank you very much. Well, we have one question. It's actually quite a big question in a way. And this is Samina Akhtar. Hello, Samina. And she said, well, she asked two questions, but I'm only letting you have one. And that's, have you had women declining continuity of carer by midwife? Emma, go on. How many?
Never ever.
Sam, how many?
I haven't practiced as a midwife. I can't answer that question. I do know that, I suppose I do know in New Zealand, particularly maybe a little bit in the past with our Pacific women, they preferred to just rock up to the hospital. Because that was what they were used to in the Pacific Islands. Now that's probably changed a lot over the years. I might be talking, way back here. But yes, there may be women who prefer, and there are certainly women who choose a private obstetrician. As I said, 6% of women in New Zealand will choose a private obstetrician. The obstetrician gets the government same LMC payment, but they can charge a fee as well. So yeah.
So not often. Okay. I will, as I always say, every week, this hour is the fastest week ever. Every time. And I want to say a big thank you to Emma and Sam for joining us, especially Emma, who's had a very busy week, and Sam, for whom it is the crack of dawn. In fact, the dawn hasn't even cracked yet. So thank you so much for getting out of your bed. It must have been 3:30 in the morning at least to join us. It's been a fantastic discussion. And I think there'll be more to come, from both of you. But I have to bring it to an end. So a big thank you to Emma and Sam, and also a big thank you to our audience. As always, fantastic questions. Some of them we couldn't quite answer, but I think there might be more debate on this. In fact, I know there's going to be more debate because we need to really push this forward a little bit more, for the sake of midwives, actually, as well as for women and babies and families. So thank you again. And thank you to Amy and Deborah and Paul, who made sure everything's running smoothly behind the scenes, and Paul especially putting the question through to me. I forgot to say, this is why I'm looking every now and then over here. The questions come through on my other screen. I should have said, I do beg your pardon. Now that this will be coming through all the normal channels, including a 6 o'clock in the morning podcast on Friday for those of you who like a little listen while you run, perhaps, or exercise. Next week, Maternity and Midwifery Hours, same place, same time. And don't forget to book for the 4th of July or 16th of September for the next festival. And in the meantime, look after yourselves, stay safe, and we'll see you next week. Take care. Bye.